For today's EMN5, I want to talk about vent settings in asthma. So let's start off with a case. You have a 35-year-old asthmatic presenting to the ER in acute respiratory distress, and eventually you have to intubate. Now you have the respiratory therapist standing there asking, what settings do you want? So are there differences in asthma that we need to think about? So if this is not an asthmatic in a normal lung, what would be our vent settings? AC would be a great mode to start with. Tidal volume for lung protective strategy says 6 to 8 milliliters per kilogram. Respiratory rate of around 12 to 14 would be good, starting at FiO2 of 100% and PEEP of 5. And remember that the predicted body weight is how you're calculating that tidal volume. So for asthma, what we need to think about is there's a very high airway resistance, and we really need to give the patient a lot of time to exhale due to all that bronchospasm. So let's see how we can change the vent to allow for that. So we can still use AC mode, same tidal volume, but we can take the respiratory rate down, say to about 10, or even extremes down to 6 to 8. Basically, you're spacing out your respirations to have more time to exhale. And with this low respiratory rate, it could be that your CO2 is going to go up a little bit. That's okay. We're going to allow for a little bit of permissive hypercapnia. Our goal is just going to be a pH of greater than 7.2. Another option is to increase the I to E ratio. So let's talk about what that is. The I to E ratio is the ratio of time spent during inspiration compared to exhalation. So you can see that the respiratory rate stays the same, but now we want to increase the E portion of each breath, make that longer to allow more time to exhale, which makes the inspiration portion a little bit shorter. So for example, in a normal patient, we might have an I to E ratio of 1 to 2. In an asthmatic, we might need something around 1 to 4, allow more time to exhale. We can also adjust what's called the inspiratory flow rate, and that's the amount of air that's forced in during each inhalation. You can imagine that if the inspiration is shortened due to our adjustment of the I to E ratio, the tidal volume might be affected a little bit and actually decrease. So another option is to increase the inspiratory flow rate, which is this first part of the diagram in yellow, where normal settings are probably around 60 liters per minute. In an asthmatic, you can force in about 80 to 100 liters per minute. So you're having a really fast inspiration, which allows more air to come in, a little bit higher tidal volume, and you still have a lot of time to exhale. So now that we've intubated the patient and put in some preliminary settings, let's take a look at our ventilator. So this is the pressure waveform you would expect on a normal lung. What part of this are we going to look at to indicate the large airways that would have some abnormalities in asthma? Good, so it's the peak pressure. So it's this top part right here. And the peak pressure is the pressure on the large airways. Let's say it's around 20 in a normal patient. But in your asthmatic, what are you going to see? Good, so it's going to be really high peak pressures and a normal plateau pressure. The plateau pressure is the pressure on the alveoli. And while high plateau pressure can indicate some risk of barotrauma, there really isn't a specific risk of barotrauma with high peak pressures as long as it's isolated and the plateau isn't high as well. And this difference between the two is a measure of the airway resistance, which of course is going to be very high in an asthmatic. Okay, so we have our asthmatic on the vent. We've tried to adjust the settings to maximize exhalation time as needed. We've reviewed our waveform on the monitor. But what if our patient starts crashing? What if they start becoming hypotensive? The main concern is that a ventilated asthmatic is auto-peeping, which happens when there's an incomplete exhalation before the next breath starts. So we're not doing a good enough job allowing them to exhale. And what happens is the air builds up and keeps building and building after each breath and causes hyperinflation of the lungs. And eventually, it pushes not only outward but inward, increases the pressure on the IVC and decreases venous return, and therefore can cause hypotension and even arrest in these patients. So you can see evidence of this on the vent in two different ways. One is on the flow diagram that we looked at earlier. In asthmatics, there's a delay in the return of the expiratory phase back to the baseline of 0. So the normal patient is here in the dotted line. You can see that they come up a lot quicker back to 0. Their exhalation happens quickly, and they approach the 0 line before the next breath. In asthmatic, however, this line is going to be much more prolonged. So you're going to see, like here, for example, it takes much longer for them to reach the 0 line. And it could be that they're not even done exhaling by the time the next breath starts. And if this happens, they can auto-peep. They keep building up the air because each new breath starts before the exhalation is finished. On the pressure diagram, we can look at the I peep, or the intrinsic peep. You do this during an expiratory hold maneuver, and you see what's the amount of auto peep that's over your set peep. So usually set peep of 5, for example. you're looking at this intrinsic peep over, and that would be an indicator that you're having some auto peeping. So signs that we talked about of auto peeping: if you have a high eye peep, we talked about greater than 20. Also, if you have a high plateau pressure, so you're expanding and expanding and expanding, and it causes pressure on the alveoli, now you're going to see your plateau pressure starting to increase as well. And if you see it going greater than 30, you should be concerned about auto peeping in your asthmatic. And also, of course, signs of hypotension. The treatment for this is, number one, disconnect them from the vent. Take the machine out of it and allow them to exhale. Get all of that stacked air out of the chest. In fact, you can even help them out by pushing on the chest. Literally give the patient a hug. Allow that air to be squeezed out of the chest and get them to exhale. And then lastly, just think back through all those settings we talked about and really try to maximize them. So 3 to remember from this talk: the asthmatic on the vent, you need to think about giving them time to exhale, decreasing the respiratory rate, having a high I to E ratio, and also increasing the inspiratory flow rate. If they're crashing, be really worried about auto peep. Take a look at the vent and allow them some time to exhale. Take them off the ventilator and give your patients hugs. Here's some resources, and thanks for joining us on EMN5.